the session that's designed for this afternoon is strengthening end-to-end access from R&D to scaling, sustainable scaling. We'll explore the interconnectedness among health product development, so R&D, introduction and launch, and delivery, which is, again, manufacturing and distribution, among other things. So we hope to discuss some practical steps to accelerate global equitable access. Just in full disclosure, as you know, I'm on the board of the Innovation in Healthcare, but I also run the Center for Health and Healthcare at the World Economic Forum, where we are working on these issues. We have initiatives, programs running on health equity side, on access side, on I listened to some of the earlier conversation on digital health and AI. We are very engaged in some of that work. So I would not bias you with a lot of comments from me, because I want to hear from the speakers here and folks here in the room. So I'll keep this to minimum. But I think one thing that we want to point out here is what happened during COVID-19. There are so many learnings from COVID-19. When we talk about access, when we talk about global health, first of all, we developed a vaccine in a record time. Within 10 months, actually, of identifying the virus, there was a vaccine that was developed. That happened because of the international cooperation, because of the public-private partnership. So global health community needs a pat on the back for that. I think that is a fantastic achievement for mankind, I would say. But it stopped there. I mean, we did develop the vaccine fast. We did manufacture lots of doses, over 10 billion doses next year, following year of the COVID vaccine production was huge, over 10 billion doses. This was, again, a great achievement. But then we ran into the distribution problem. We ran into access problem. And there are a variety of reasons why that happened. Among some of those are nationalism, export bans. So there were vaccines in particular part of the world, but they were not allowed to go to other parts of the world because the government said, no, we want to vaccinate our own citizens 4 times, 5 times before we send a single dose out. So that's a challenge, and so I think now we are working, the international global health community is working on that to solve for some of those things. There is a regional vaccine manufacturing initiative that we are running together with Gavi, CEPI, WHO, National Academy of Medicine, where we can make sure that next time around there is a manufacturing facility around the world in various regions. So I think that's something that some of us are working on, but that's not the whole thing. I mean, there is so much more that needs to be done. And that's the session that we have designed today, where we will look at the whole continuum of biomedical innovation, from R&D to regulatory authorization. As you know, regulatory is a challenge when we talk about country level introduction. And we will look all the way to last mile delivery and equitable access. So to do that, we are joined by experts across those areas to help us unpack key insights and lessons for the future. To delve deeper into this topic, we will hear first from Katharine Olson on the work that Duke Global Health Innovation Center and Innovations in Healthcare have been leading for some time. Katharine is an analyst at Duke Global Health Innovation Center and Innovations in Healthcare. So let me invite you, Katharine, here to enlighten us with your remarks on this subject.
Thank you for the introduction. So as has been mentioned several times today so far, we've had immense progress and millions of lives saved with the advancements in biomedical innovations. And there's lots of products that are really promising in the pipeline. But as we think forward, we know that there are several challenges and opportunities that are still faced in this pathway from ideation all the way to sustainable scale. So we know that there are gaps all along all of these steps. And we know that there's a disconnect between the distinct conversations and funding opportunities that are happening at each step along the pathway. And we can also understand that multidisciplinary end-to-end approaches that bring together really diverse global perspectives really have the potential to generate and share insights and translate evidence to policy and practice. So here at the Duke Global Health Innovation Center and Innovations in Healthcare, this is just a quick snapshot of some of the projects that we've undertaken in this field. And as you can see, the real key takeaway here is that most of our projects are touching upon multiple points along this pathway and really trying to look and push the field more towards this end-to-end view on access. So just to start off, we have this framework that we worked on, which is the speedometer framework. And we've developed this to systematically analyze the pathways, timelines, and influencing characteristics that can accelerate the time span for the introduction and scaling of health innovations. So this incorporates both global and country milestones. So that will be key time points from introduction or from ideation all the way to scale. So that will be things like the date of ideation, when a product got stringent regulatory approval, maybe when a country regulatory approval was reached, when a pilot was introduced and completed in a country. But this framework also takes into account what we've called characteristics. So these are other factors that influence the scale and timeline in the introduction of health innovations. So this is things like the cost effectiveness of an intervention, the specific type of an intervention, so looking at vaccines versus drugs versus devices, all of that, and even down to the country burden of disease and how that may influence the timeline to scale. So we've analyzed 59 interventions in total using this speedometer framework. And as we found out, the timelines to launch and scale biomedical innovations are often lengthy and variable. As you can see on this figure here, the timeline is in years. So most of these interventions are taking years to go from ideation to first country launch, and then still years further to make it to only 20% uptake in countries. And I think that this is really important to look at too, as we saw COVID vaccines were really, really fast. But you can see here, non-COVID vaccines may take over 30 years in some cases to go from ideation to first country launch. And as we think about accelerating these timelines, many more lives could be saved if these were shortened, both from ideation to first country launch and from first country launch to actually uptake to hopefully above 50 or 80% scale. And specifically, as we think about some tools we can use to accelerate these timelines, market shaping is one of those tools we can use. And we know that market shaping is the act of intervening in a health market to try and address some market shortcomings. So that may be things like demand and supply imbalances or high transaction costs in low and middle income countries. And as we can see from this slide here, more than $9 billion in investments have been made over the last decade for market shaping. And most of this has gone to vaccines. And we know that this is a field that is really moving forward and trying to address some of the challenges. And as we think especially to COVID, like we mentioned before, that has really accelerated some major market trends. So things like regional manufacturing or decentralized healthcare that market shaping will need to try and address as we move forward. So like I've said, market shaping has improved access to health products. Specifically, we think of something like the pneumococcal advanced market commitment and other market shaping activities like that. They've really helped improve access overall, but we still know that there's limited available data publicly that can help identify market failures and help inform market shaping decisions and performance. There's also an absence of widely shared frameworks and standardized measures to make sure that we can monitor the performance and the unintended consequences in this field. We know that there continues to be a lack of engagement with low and middle income country stakeholders, and there are several barriers to actually implementing effective market shaping interventions. So we continue to have fragmented markets, lack of transparency in regulatory processes, and difficulties in creating sustainable incentives for multiple geographically diverse manufacturers. As we look specifically again a little bit closer at COVID, we know that it moved significantly faster than some of these other biomedical innovations we've seen, but there were still several addressable bottlenecks that really slowed the introduction and equitable access of COVID products. So the key takeaway with this slide here is It took 15 months to move from US FDA approval of emergency use approval to the first reported delivery with the innovator product. It took 23 months to go from the innovator agreeing to license the product to actually then having a generic delivered in country. And all along this pathway, we had long timelines for finalizing supply agreements. We had difficulty trying to really generate and understand what accurate demand was for these products. And based on our estimates, we think these timelines could have overall been shortened by 9 to 10 months if we were able to move more quickly to get affordable pricing to the innovator product, really improve regulatory approvals and make those more rapid, and also to have faster commercialization of these generics, which would have been really possible by having accurate, clear demand. And as we think about once products actually make it into country, we know that health systems need to be fit for purpose to really help improve access to health products. And we know that programs need to really understand beyond just getting a product into a country, that it really needs to understand system capabilities. So things like, do we have the correct workforce present to help with this? What is the financing structure in this country? Do we have accurate or adequate health insurance schemes? We need to understand the policy environment. So has this product been integrated into national clinical guidelines? And we need to also address the patient experience in order to have impact. And as has been mentioned several times throughout the course of today, we know that the private sector can really help support a lot of the efforts that are going on in the public sector as we think about access to healthcare. And we know that these global health programs that are supported by the private sector are really growing in quantity and scope, but there's often limited information about the actual results and impacts of these programs. And we specifically have been involved in several different private sector organizations to help them think about how you actually implement a program that takes on system capabilities, financing, policy, and patient experience, and then also thinking through how do you measure your actual impacts across all of those different factors. So just to kind of summarize here, as we think about going from R&D all the way to scale, there are several steps we can take to really improve this overall pathway. And so we really need to think about all across this pathway. In R&D, there's several things we can do. We can establish stronger regional clinical trials. We can create more effective funding mechanisms. We can really try and dig down on some of these enduring bottlenecks as we think about product categories and going across product categories and disease categories. So we need to think about access to intellectual property, access to technology transfer, improving and harmonizing regulatory support and oversight. We need to really move beyond this idea of product market shaping and think more about how do we address overall service delivery barriers and create stronger demand for products. We also need to commit to transparency and learning across all of the stakeholders in this entire spectrum, including more public reporting of data, outcomes evaluation, and sharing of negative results and best practices. And really all across this end-to-end pathway from R&D all the way through scale, we need to think about enhancing the coordination of stakeholders in each of these groups, and also incorporating this end-to-end planning and coordination and capacity building to ensure that everything that's going on in R&D is also informing what is happening at the scale step and vice versa. So I will pause here and hand it back to the panel.
Thank you. Thanks, Katharine. Thank you for the great points here on the end-to-end approach. Now, let's get on with our panel here. In the interest of time, I think we should move on. I think for this discussion to talk about last mile access, to look at the insights and learnings from our panelists, I would like to invite the distinguished panelists to the stage now. First one is Edward Booty, CEO of Reach 52. Is Edward here? Then we have Sam Gwer, Executive Director, Afya Research Africa. Sam. And next one is Louise Agersnap, Head of the WHO Innovation Hub, World Health Organization. And finally, Jonathan Miller, founder and CEO, Airborne Lifeline Foundation. So we will begin by looking at the issues on the front lines, where we look at the delivery innovations and demand generation. I think these are important to understand from public and private sector perspectives. First, we will have some individually directed questions to each one of you, maybe 2 at a time. And then we will have some questions from me and from the audience for all of you. So the first one is directed to you, Ed and Sam, since each one of you lead startups that are refining entrepreneurial approaches to sustainable access to health products and services. Can you tell us about your specific models, your learning, your journey, and how you are especially addressing access to health products such as tests, treatments, and vaccines, so the whole gamut of medical countermeasures. So over to you, Ed, and then followed by Sam.
I'm first. Hi, everybody. Thank you for the intro. Hello, everybody. I'm Ed. Run an organization called Reach 52. Over 52% of the world can't access essential healthcare. So 4.5 billion people, according to the World Health Organization, which want to reach the 52%. Started off training health workers to collect data on their community's health needs. So we work in rural areas. Health workers would survey their community. Based on that, we'd run public health programs with different funders. So if we see big spikes in malnutrition or low vaccination or whatever it might be, through those surveys, we'd get funding to retrain health workers to re-engage specific households, working with, UN agencies through to big pharma to fund that. More recently, I think the reason I'm on this panel versus a different one, what we sort of changed is because we're doing a lot more around end-to-end. The biggest problem we saw was the high cost of medicine that was either not available, basic products not available, or not affordable, too expensive. So back in the last year, we launched a range of where we licensed 32 products from major multinational pharmaceutical company. So we became a sort of pharma company, and we launched our own range of generics as well. So a Reach 52 brand of medicine. We've now got 48 products available in about 28,000 pharmacies, clinics, hospitals globally, 400 distributors, pretty much nationwide in India, growing in Zambia, Zimbabwe, DRC. We've just appointed a distributor as well. So now we're doing the original model, training health workers, collecting data, but entirely financed through the margins on the essential medicine. So we run about 7,000 screening events a month, screen about 1 million people a month, and that's with the profits from the pharma side. That's what we do.
Excellent. Thank you. Thanks, Ed. Sam, your perspective?
Yeah, so I run a network of medical centers targeting rural communities in Kenya. 25 of them unique in the community co-ownership model that we implement, and in supplementary enterprises that enables us to deliver subsidized care to communities that would ordinarily not afford private healthcare. We provide integrated offering at the primary healthcare level. That means providing more than the traditional primary healthcare elements of care, including NCDs and disability care services in a space that also focuses on infectious diseases, maternal and newborn healthcare systems. And that's out of belief that the human is whole. And a lot of times there is a cross presentation with the NCDs and infectious diseases, and we just need to handle that as a whole. We also do digital health, and most recently over COVID, we have developed unexpectedly a neurology enterprise, which has grown annually on average by 247%, and whose revenue is now helping us to cross-subsidize some of our work with rural communities. For us, our model and our sustainability model is always changing. And that's what it is. The environment is never the same when you start. So if you're going to be implementing something over 10 years, the realities you had 10 years ago are not going to be the same now. And it's always a continuous experience of experimentation. And I'm a big believer in integration. I think that many tools and technologies, particularly in healthcare, cannot stand by themselves in the market, and they need to be anchored in systems and working services. And things are a little bit different in our space in that if you're going to develop a digital tool in this environment, you will think little of electricity, of network connectivity, of clean water, but we have to figure that out where we are. And you throw in education and compliance, and so lots of bits and pieces that you always have to figure out when you're trying to trial new interventions and new innovations. Yep.
Great, thank you. Let me turn to you, Louise, to get a perspective from the innovation side, from WHO side. Through WHO Innovation Hub, we are developing scalable, sustainable, and demand-based models to support national governments with health innovation, including product introduction and scale-up. So my question to you is, what have you learned so far from this exercise? How best could national governments work with private sector to accelerate access? So again, going back to public-private partnership.
Yes, thank you so much. And yeah, let me first say that the key word for us is demand. And I think in the innovation community, we love to talk about the supply of things, the shiny gadgets, the thing, the solution, etc. And that's natural. I love it too. But given that we're a member states-based organization, as I've said already, and we have 194 member states, 150 country offices and more, we have a really good opportunity to convene and to listen to what it is that's needed in countries. And I want to say it's not just governments, it is also the communities and the people that they serve. So that's our starting point. And then I think when we look at this end-to-end process, that's a bit deceiving because it looks linear, but it isn't linear. And I think we have to, as we look at how do we fix all the problems that we see in the ecosystems, let's look at how different problems are. That it's probably quite different to try to scale a drug than it is to deliver babies safely, or have, look more broadly at maternal and child health. It's a whole different matter, and the complexity increases. So with the complexity, I think we have to be open to looking at how can we work differently? How can we, does it make sense to have the same type of KPIs and short-term projects when we try to fix bigger, complex problems in public health? And I think the answer is no. But then the question is, what comes instead? What is it we can do? And I think part of the solution lies in the public-private partnerships, but that is a little bit outdated to talk about public-private partnerships, if I may, because it's more about a coalition of the key stakeholders, including communities, including those that will be using the actual the interventions that we create, and then maybe not looking at scaling different things, but looking at designing together in a portfolio of interventions that can together create system shifts. So what I'm talking about here is to take a system lens to solving complex health issues. So that's where we are right now, and we are working around one of the key things we do in the WHO Innovation Hub is something we call the Demand Catalyst Program. And it's demand from countries, and using WHO's presence and trusted relationship with our member states and the people they serve to understand what the real demands are and have them be articulated clearly to the ecosystem, so that the ecosystem can begin really rallying around an intent, a mission together. I think that's a little bit missing. There's a mismatch between the needs and the solutions, and somebody's got to step in and help convene and create that clear vision of what are the needs here and how can we together deliver against those. And then one last point about learning, because if we are open to not having rigid KPIs that we set 2-3 years out in the future, but say we actually don't know what the KPI is in 2 years. Let's be open to that and then have a mechanism for learning as we go and really designing for uncertainty and being open-minded to learn and pick up the lessons that we see along the way and then adapt. Then I think we will actually be able to deliver more to the people who need it.
Absolutely, and a really good point here, Louise. It's more about building multi-stakeholder coalitions than just looking at the government coming together with private sector. So great point there. Let me just move on quickly to you, Jonathan. You told me that you're not a healthcare expert, you're not a physician, but I think you bring with your experience or just looking at what you do, and it's like a great experience from other industries, from other type of work that you have brought to the healthcare side. So you've been able to translate experience in aviation and international development into a model that's focused on getting qualified healthcare our health workforce to rural areas, starting in Botswana. We know that there is a healthcare worker shortage around the world, but getting them to rural areas, that's another story. So you've been able to do that effectively, at least in some cases. What are your learnings through this work, especially about last mile access in rural areas? Jonathan?
Yeah. Hello? Yeah, okay. Most people don't want to hear me. For starts, I first came to Africa in 1982 and became the Peace Corps director in Botswana in 83. And I kiddingly say, but I really mean it, that once Africa gets in your blood, it's like malaria. You just don't get rid of it. So I've had a love affair with the continent for 40 some odd years. And then I went on to senior positions at the National Security Council, the White House, et cetera, State Department. And I came back to Africa, and it was in the midst of the HIV pandemic. And blame this all on Joy Pamafi. I met Joy when she was health minister in Botswana, and Botswana was raging in HIV/AIDS, as were many countries, but at least Joy and Festus Mohai were proactive. You could go across the border, and President Mbeki was in denial. And she knew I had an aviation background, and I have a passion about rural health. I really feel it's my sort of mantra that people in remote areas deserve at least a modicum of quality medical support that people get in urban areas. In the urban areas at the time, people were getting treated in Gaborone and Francistown, and they were being ignored out in the rural areas. And so actually, Joy, who was a visionary, still is a visionary, and I discussed whether we could start delivering, and she said, make this holistic, don't make it just HIV/AIDS, preventative care specialists. And we thought that was a great idea. And then Joy went on to the WHO and the World Bank, and Sheila took over as the Minister of Health. And I created a foundation, pretty audacious on my part. And then we took it with the U.S. ambassador's support to what was an organization then called BATUSA, which was CDC. And there's a story here, and that's why I'm saying it. CDC people said, your idea is luxurious. It's, if we need to send specialists, they can go out by land. And so if they go out by land, we're wasting several days of treatment. And if they go out by land, they're never going to come back and do it again. So I had this agreement. My wife said, CDC wouldn't support us. So we mortgaged our farm. That's how we started funding it. And we started flying scheduled basis. So we'd fly doctors, preventative care to very remote areas in the Kalahari Desert or up in the Okavango Delta or whatever. And we were flying doctors from UPenn and from Baylor. And it was highly, highly, highly successful, so much so that we then expanded it to do pediatric HIV/AIDS flights with Baylor up in Malawi. And then thanks to both Mark Dybel and Debbie Burks, I got sucked into the Pink Red Ribbon Initiative in Zambia and started delivering HPV vaccines. Long story short, we finally did get funded, and then by PEPFAR, only because we were beating up the delegation from Texas and Pennsylvania, were beating up Mark Dybel. But anyway, we were highly, highly successful, and we proved the model that there's so many. If you could take a specialist who would leave Habaroni in the morning, but keep the same schedule, so the same pediatrician would go to the same village on the same schedule. The mother would come in from the bush if she knew it was the same doctor on the same day, but you had to keep the schedule, had to keep the same specialist. That was so I suspended that when I went off to run Peace Corps Africa. And then the minute Peace Corps Africa was over and done with, I stepped down. It was in the middle of the COVID-19 pandemic. So I picked up the phone. Who did I call? I called Joy. Within 3 weeks, we started delivering COVID-19 vaccines out into the Kalahari Desert. We went up because of the economics, we inoculated the staffs of all the safari lodges because the economy is important here. We went in by helicopter along the Namibia border, and people came in literally out of the bush. I say this because, and we're already negotiating with the government of Namibia, the government of Malawi, and the government of Zambia to go back in those places, is that I'm a logistics guy. You guys develop the drugs, you develop all this sort of stuff. All we do is we provide a solution to get scarce resources at the last mile, and that's it.
It's great. Thank you. What a fascinating story here and the impact that you are making, Jonathan. I think we want to get to the audience here, but let me ask a couple of more questions to all of you, not directed to any particular panelist here. As I said earlier in my intro, we are coming up with great therapies. We are doing really well on R&D. As I said, we have wonderful cancer drugs, treatments. I mean, we are not 100% there yet, but a lot of progress there. With obesity also, you see what's happening. And we have gene therapies and other. Instead of, talking about pricing and some of the other access challenges, we also see that there is a challenge on the healthcare system side, especially in the low and middle income countries. We see that many systems in LMICs are not ready and resourced to enable fast introduction and sustainable scale up of these new therapies. In your mind, what are the top 1 or 2 things that need to be done to support health systems to accelerate access to these emerging therapies or emerging technologies? So whoever wants to take it first, you're welcome to do that.
I can
Yes, go ahead, Sam.
So I think first with the awareness that in Kenya, almost 50% of the healthcare is provided by the private sector. And what that has meant is a lot of technologies have entered the country through the private sector first before getting into the public sector. So defining and recognizing that pathway is really crucial for new technologies. But I also think we need to innovate around how we can finance the private sector to access these technologies. And the Chinese equipment manufacturers have done a good job in the country. And what they really do is place equipment in facilities and work a revenue model that gets you to pay back. And I know a couple of Western companies have tried that, but the Chinese are really aggressive and really successful in making that happen. So I think that we need to loosen up and be willing to risk with such models of supporting access. We want the same things as Western populations. We want good healthcare. We want self-injectable family planning. And we have to think about access and pricing and the models to deliver that, because then it works if we are aligned.
Very good point, Louise.
Thank you. I think we have a lot of innovative approaches at hand that we are simply not using. There are many proven service delivery innovations that have a lot of evidence of impact, but they don't go to scale. So they may exist somewhere, they're implemented, maybe they're benefiting 100,000 people, maybe a bit more, but we could actually scale it to 100 million if we had concerted intent and effort and coordination. We're trying to promote that in from the WHO Innovation Hub to look at the evidence-based proven service delivery innovations, many of which come in the form of community health worker networks, which exist in many countries. It's a resource that's already there, and combining it with digital solutions. You all know the examples. I think this crowd have seen the Mom Connect, the prompts, etc. There's also something called Mamás del Río in the Amazon area, with community health workers equipped with tablets, with videos that both give themselves health education, but also use the videos in local languages to communities where they go out in the Amazon River, to remote communities, to demonstrate not just through words, but also through videos. So it's a different way of just using digital means. It's not rocket science, but it's a powerful combination, community health workers with the right digital tools. I also want to say it's about not, contributing to creating more silos. So the more that we can think integrated services, we take what's called a primary healthcare approach to innovation scale up, and it has three components. It's the integrated service focus, it's multi-stakeholder action, and community engagement and empowerment. And with those ingredients, I think you can come far. But we have to be careful not just to look at, be blinded by the solution or the drug or the device, but looking at all the intangibles around it in terms of human behavior.
Absolutely. I mean, we see this time and time again where doing a pilot or introduction is not a problem. You can do that, but how do you scale it up? The scale up is a real challenge. Any other perspective from the panelists here on this?
Well, on the scale up thing, it's not in this area, but I took Joy up to Boston on Tuesday to go to a place called Ginkgo Bioworks that is doing pathogen testing.
Yeah.
And we are doing a rollout. They've already done some in Rwanda, and we're doing one across the Zambezi River, the border crossing in Botswana, and in an abattoir because of and Joy said afterwards, "Oh, I'm going to go see President Ramaphosa at the end of October. I really would see how quickly can you roll this out in South Africa." And I'm like a deer in the headlight. I'm going, oh my God. But you're right. We've proven some things, whether it's this pathogen testing or we've proven something else, but to try to scale it up to where it's really relevant is extremely difficult. But it should be tried, and I think we shouldn't be modest about it.
Yeah, I guess just from my point of view, I mean, I always struggle with this. So yeah, we distribute essential medicines in the communities we work in. A lot of the time, basic second line NCD treatments aren't available. So I always sort of struggle to get into the bleeding edge innovation if you don't have, basic diabetes products or basic screening even. So that's the sort of communities we work in. As a sort of example, we just did a survey of like 16 essential maternal, newborn, child health commodities. And we couldn't find 2 of the 16 in 400 pharmacies that we surveyed. So almost like before starting talking about big innovation and how we're going to do oncology, I mean, I think it's really important just to lay basic groundwork, pay health workers, get essential generics, blood pressure monitors, blood glucose monitors that exist already. I think the other reason of doing that is you can't expect to jump from, for example, no screening at all to oncology screening. So by implementing the basics, it's also going to give that educational curve, for lack of a better phrase, to allow people to advance to more interesting technologies. Beyond that, though, 2 approaches that I think we see working, even with prescribing second line diabetes products, for example. Rural doctors tend to still copy doctors in the city, for lack of a better phrase. So having pilots is endless pilotitis, absolutely 100% agree wrong, but decent exemplars in an urban environment that can be used because often, you know, that sort of relatable physician that could educate the rural areas, we see that working. And you're never going to get a rural doctor to prescribe a new treatment first. So we do find you have to work from the out and in. And an interesting project we have done recently from arthritis, actually, there's not enough rheumatologists, this kind of thing. So therefore it was a doctor to doctor telehealth service. So working with primary health doctors who are subsequently supported by the specialists in cities. And in terms of actually decentralizing more specialist care, we found a sort of a doctor to doctor telehealth network was actually quite effective.
It's great. We see that happening in many places, in many geographies now, especially the telehealth is expanding so fast. Let's just move on to the demand side of things, to talk about demand a little bit. Demand in low source settings, recognizing that need and demand are very different at times. How should we think about this? How should we think about demand in LMICs? How do we make sure, as somebody else also said earlier, that a need is very different than the demand? How do you guys think about this? So if anybody wants to talk about this, you're welcome to start.
Yeah, my personal views. I mean, this is something I probably think most about, just personally speaking. I think it's probably the biggest challenge we face, a lack of stable, sustainable demand for products. Makes it incredibly different to forecast, to procure the right amounts, to know what will sell. And even we've had it nowadays, we've had such frustrating projects where, let's just say there's insulin or a product, nutrition, $10, say, out of pocket. We bring it in for $1. So we've solved the supply issue and the affordability issue. It often doesn't move at all.
Yeah.
So you solve that entire, there was the community where there was like $25 insulin. We got it into the community for $4.
Yeah.
That doesn't mean you start selling insulin all of a sudden. You need training the doctors. You need, like a whole range of services. So yeah, the lack of sustainable, predictable demand, I think, is probably one of the biggest issues in aggregation or any sort of supply intervention, and they have to go hand in hand. I mean, I often get asked or implied that Reach 52 does too much, training health workers and trying to be a pharma company, but I wouldn't do one without the other. It would be absolutely no point to run this company if we didn't look at demand generation alongside supply. And that was definitely one of my biggest learnings of, setting up the business.
Louise?
Yeah, really interesting. It's hard to get right indeed. And I think this notion I mentioned earlier of the coalition, a really important byproduct of having a coalition, and I'm using it in a very loose way. I mean, coalition meaning having that space where the different stakeholders can have ongoing conversation and learn. The byproduct is that you create ownership, and you create a sense of, well, you have a constant reality check with what you're doing, and that allows for, I would imagine, avoiding situations like that where you have fixed one problem over here, but the ones who are supposed to then step in and do something are not aware. So it's about that sort of transparency about the intent and how we are making progress together and what we're learning and how we fix things together along the way.
Yeah. Yeah. No, I think that's, do you have a point, Sam?
Yeah, I think that data systems are your friend in respect to understanding need and demand issues. And you have to be willing to set that up, even though it will not have an immediate apparent impact. And you have to be willing to continuously learn, because you never get it right. And if you get it right today, it may not be right tomorrow.
Yeah. Absolutely right. I mean, demand is so critical here. I mean, we are going through election period in the US, for those of us who live here. And every time we go through elections, we hear its economy is stupid. In my mind, when we try to introduce products in LMICs, it's the demand is stupid. If you can't solve for that, if you don't have, a good demand, it doesn't matter what you do, it's not going to succeed.
Let me say one thing, as a person who worked, I was also a chief of staff on Capitol Hill and worked at the White House, et cetera. I'm not being partisan here. Whoever wins this next election, the glory days of donor in the United States are over and done with. Whoever is going to be elected in the Congress. So that well is drying. So the glory days of PMI and PEPFAR are setting fairly quickly. And so if anything, in the other countries, the Europeans are going through horrific budgetary issues. It cries out even more for efficiency and creativity across the world. I'm speaking on my political hat.
Sure. No, but that's a really good point. I can ask questions here all day long, but let me stop here so that we make sure we have ample time from audience to ask questions here. So over to you, either here in the room or people online virtually. Feel free to ask questions with our esteemed colleagues here. We have a question here.
Hi, thank you so much for insightful discussion. So my name is Phunthip and my background is medical doctor from Thailand and I'm recent MPH grad from Johns Hopkins. So I have the kind of general question. So when you talk about kind of monitoring and evaluation, so I wonder that is there any kind of specific KPI or indicators that you use that to evaluate whether this innovation is impactful enough or sustainable enough? Are there anything that you use to monitor that?
Who wants
anyone?
to take? Anyone, I guess.
Is there a specific KPI that we'll use to confirm that an innovation is working? It's a bit of a tricky one because then we are our rural centers. We are in a space where the communities that we are targeting are really, really poor and not able to afford most of what we offer, and we have to think about how best to provide that to them. But in such a space, then quickly we are interested in impact and whether it solves for the health solution or health problem it's supposed to solve, and then we are willing to explore the logistics of delivering that solution, whether it really makes sense, whether it's efficient, it's cost effective, and so it's going to be changing depending on what you're dealing with. But yeah, those are some of the key issues we'll be interested in.
Yeah, for us, we just look at lives improved. So we work across different health areas. A life improved would be somebody taking one of our treatments. It would be somebody coming to one of our events and getting screening. Often we have volunteer doctors at the events that we fund. It would be somebody getting a consult. So we just look at life improved, and then there could be a different definition by life improved, depending on the service we provide or the disease area that we work in. So it's like trying to take them a step forward on the patient journey, if that makes sense. Like if you were already screened, it might be seeing a doctor or getting a treatment. If you've already got a treatment, it might be getting a treatment again. I would say this is tough though, because we often get grants and external funding, and we talk about sustainable scaling. I would say the fragmentation of M&E is probably one of the reasons that we're smaller than I'd like to be now. Different funders manage to reinvent. We think we're doing 4 diabetes screening campaigns this year with 4 different funders, one pharma company, etc. We've measured it in 4 different ways. One of them is like a 1-slide thing. One of them is this like beastly, like 50-line Excel with all sorts of random stuff in it. So I do think harmonization of metrics. There is things like Iris Plus that have come out of Global Impact. I can't remember the name, but there are some standardized metrics that can be adopted. And I think funders should do a lot more around that, because I do think it keeps social innovators perpetually subscale to keep making us measure the same thing in different ways a lot of the time.
Yeah, otherwise could be a moving KPIs all the time. Louise, did you have a point?
Yes. So yes, I concur with what you said. It's in the end, it's about the impact on human lives. That said, people say it takes 10 to 15 years to scale an innovation. So it's also like, what do you then measure until you actually can say confidently that you are impacting lives? And sometimes you also realize if you're open to learning in the course of implementing and scaling, that there are other impacts that are also positive, and there could be some that are negative, but you got to also capture those. And just one example, one of the first innovations that we've helped scale was in Somalia, where the government at the beginning of COVID wanted to have innovations for medical oxygen delivery. And the problem was one of electricity. We helped install solar-powered oxygen concentrators, which in fact ended up being more solarizing small primary care clinics with oxygen concentrators. And one positive impact of that was actually improved mental health of the doctors. Because they were saying, you know, before they were not, without electricity, they couldn't do much. No electricity, no water. I mean, what's the point of a health facility? And you're still there, you're still trying to do good, but in most cases you can't and people die. So this time they were actually able to save lives, and it was amazing for them. And they just had a completely different feeling around their work, obviously. But we tend to forget these things. So that was a positive surprise.
My big, I'll use an example. The waiting list for women in the Mound Hospital was 6 months. 6 months. So we were looking at cervical cancer issues. And my big win in the last year is that we now take OBGYNs on a regular basis up to Mound Hospital. I mean, I can't tell that in a metric to a donor, but I know that that's made a difference.
Good, thank you. Other questions? Okay. There's one in the back and then.
Okay, thank you, Alfred Yaboa Grameen Foundation. So based on your experiences, are you able to highlight some of the challenges, you know, in getting governments on board, in scaling some of these solutions? And I mean, from where you sit, what's the best entry point to get governments on board? Thank you.
I can speak to our experience, and what has happened in Kenya over the past 10 years has been a change in the health government systems with devolution of healthcare to the counties. So they do have some latitude in decision making and procurement, and that has been an easier entry point dealing with counties. But I think it's useful that at all times you engage at all levels, from the central government to the counties to the district hospital. Team members feel very slighted if they have been left out, whatever level of the chain they have been in. So it's always good to have a multiplicity of engagement.
Any other question? Yeah, Louise.
Well, just one concrete thing we're doing, which speaks more to WHO's more traditional norms and standard setting role, is to develop a guidance on scaling of innovation in the public or by the public sector. That's in development now, and we'll be speaking to many experts to inform that guidance, and indeed a lot of people who deal with these things on a daily basis in countries. So, but that guidance plus a toolkit that will come with it, it's not going to be a silver bullet, but it's going to be a pragmatic guide based on evidence on how do you best do this step by step. Not a linear process, but how do you build those coalitions? How do you listen to users and involve them as you implement new approaches? But I would say generally governments that we meet are very keen to do whatever it takes in an innovative way to save more lives. They're very open to this stuff, but they need some guidance on some tools, etc.
I agree with you on the government side. Frankly, I use an example that when I was running Peace Corps Africa, and we kept saying, well, the agreement says this, and we had a visa issue. And I said, well, why don't we listen to the government of Tanzania? They may have some valid points. Well, the same thing as we listen to the countries that we operate in, they're easier to deal with. And I'm going to step on a lot of people's toes right here than CDC and USAID, because they think they know everything and it's a one size fits all thing. And we have to listen to each respective country and within the medical community and then within the districts and into the midwives, they know what they're talking about. It's not the Harvard MPHs, I probably insulted half of you all, that really think that they know everything. It's so I find the governments, if you respectfully listen to them, are easy to deal with, relatively speaking.
guess just my experience, probably 2 points I'm going to make. One is, yeah, we predominantly work in private channel. So we're looking to lower the cost of medicines, generally out of pocket, generally private. But we do work with the government to train the health workers, fully integrated. For us, it's always been quite easy because there's like genuinely authentic, intentions of good public health benefit. I think the reason we've managed to maintain that, though, it's actually kind of a metric we track, but I'd say we say no to about 50% of projects. If you're trying to lower the cost of family planning products, for example, it is genuinely more affordable. You're genuinely trying to train. Government's quite easy to work with. We've tried to get projects through before where they're like too commercially orientated or whatever. It's very clear that it's not necessarily in the interest of the country, the patient, the economy, whatever it might be. And then it's a pain. So I think for us, it's actually about genuinely just taking projects that are in the interest of the system and not being afraid to say no to money. And that we definitely got that wrong at the start, and we definitely had problems. But if you're doing good public health work, even if it's with private sector, governments are reasonable people. But before that, when I first started Reach 52, my brother's a diplomat, and he said there's 3 Ps of working with government. Got to be very, very patient, very, very persistent, and very, very polite. And just so patience, persistence, and politeness is the way to make it work. And it takes sometimes 6 to 9 months, right? So 3 Ps.
Very reasonable people in the government. Well, so are the Harvard MPH. They are also reasonable people. I think
I'm usually in the witness protection program.
I think we have a question here. Okay.
Fernando Ruiz from Roche. About the interesting issue about the stakeholders coalitions and public-private partnership. I was wondering if we have the mechanism and the countries have the mechanisms to perform this kind of new arrangement, because stakeholders usually have competing interests. If we add markets, we will have market constraints and market competition also. So if we already have problems with the public partnerships and the governments trying to perform this, I would like to know, what do you oversee about the implementation of this kind of arrangement?
Who wants to go first?
I can go first. I'm the one who launched the idea of these coalitions. No, I think one of the design tricks here is to get the intent established. It's not a public-private partnership for the sake of partnership. It's because there is a public health problem you're trying to solve, and you got to have that established first. And then I think it's important to have a neutral broker, a trusted broker, and that's usually public sector, establishing the intent and being the convener, or a UN entity of sorts, could be WHO. We're trying to assist in that role of being a broker, quote unquote, or a convener, facilitator of the necessary conversations that must be had. And I don't think it's about over formalizing coalitions, and because then you spend half of your time in formalities and transactions. It's about keeping it light and making sure that we're meeting around a topic that's of critical importance, because people are dying or people are sick. We need to do better in delivering health services. That's a legitimate ground, and it's not driven by illegitimate interest or other agendas. It's really creating that safe, clear space about why are we here and what are we trying to solve for. I think it's possible, but I'm an optimist.
Great to hear that. Anyone else? Sam?
And now that you asked that, I think for sure there will be competing interests, and the monies will also be different. So a more moneyed stakeholder may have a bigger presence in such partnerships. But I think that it could help to define rules of engagement that essentially speak to how people should participate in such, or rather how teams should participate in such engagements prior to implementing them.
Yeah, Absolutely. Ed?
Yeah, we just echo for what it's worth. Yeah, neutral convener. A lot of our industry partners would often call us that. So yeah, we'd work with the industry. We'd obviously have to work on pricing and this kind of stuff. And we're often pretty direct and blunt about what we will and won't do. But then often government will put in money and they will fund some screening. I mean, we've done some great work in like hepatitis B screening, for example. We got affordable treatments. The government could see that the treatments were more affordable. They therefore put HPV DNA tests, you know, in the PCR machines in the hospital. So yeah, having that sort of I don't want to call us a middleman, but that kind of thing often does help. But it is definitely about the authentic public health interest that sort of glues everything together. And if that's misaligned, it doesn't work, for sure.
Excellent. The screen is showing me now 5 minutes warnings, but I think we have a couple of more questions that we can take quickly here.
Should I? Oh, hi. Well, I can go next. I'll keep it brief. Ripin Pasha, and I'll represent personal capacity as a former entrepreneur working with young entrepreneurs and also in the global health space, and really appreciate what you bring out of the issue of it's about the demand, and as the same way that, you know, Shyam, you said how we here in the US is about this, the economy is stupid, is like there's a demand element, right? And so many of times getting the demand from our populations is about getting them the right information and engaging, as we know, the most of the population. And in so many countries where we work, the biggest issue is that we have a lot of young people who are out of jobs, who is affecting the elements of both solutions coming from the ground as well as some of the issues that governments care about, which is stability, the economy. How are you working with getting data into the hands of young entrepreneurs so that they could be driving the solutions and then engaging them into being part of some of these solutions, especially in you know, how we can think of the next wave of shocks that could be you know, affecting their communities. Thank you.
Insights?
For starters, you should be talking to Jim Murray, who runs the presidential precinct. I'm on the advisory board of the presidential precinct, who works with young entrepreneurs from around the world. They come together and literally they are unbelievable. So I just say that as an aside. Too bad Jim's not here. He's already gone off to a presidential precinct meeting. But they bring in brilliant young entrepreneurs to the United States for 6 weeks in Charlottesville. And then they go down now, there's a new regimen, they go down to Dallas to work with the business community. But there's a whole pool of people that are aspiring for what you're talking about.
Okay.
Yeah, I'm pretty like practical on how we've done it, almost like operationally. So yeah, so we run public health programs with health workers and so on in 7 countries. And then yeah, pharma distribution separate business unit almost. We really wanted to get local participation, local organizations, decentralization, all that good stuff. Way more trusted, no government, youth organizations are just so much closer and would have way more trust than we have. We were pitching them nonstop. We were trying to like get out there, approach them. They often don't have websites, especially the really small, really grassroots ones might not have, you know, literally a website. So we just started running RFPs 3 times a year. So we actually put out a request for proposals for implementers, where you can actually apply to us to help us to implement our programs. We're small, like we're not a big organization, right? But we had 1,000 proposals from 47 countries to help us implement public health campaigns. And a lot of them were like small HIV youth groups and this kind of stuff, really small organizations. We did a simple like 5-box RFP, nothing crazy, nothing long, anyone could do it. And we now work with about 17 of those implementers, and they're really, really effective. It's actually more cost effective than us doing it ourselves, because if you work with one of these local organizations, you save a bunch of time. They can get the government permissions quicker. They're already known to the community. They're localized. They can help inform. So yeah, we actually just stuck out an RFP on our website and put it on some, you know, funds for NGOs.org kind of free websites. Wow. And we had some smaller organizations apply to us that we now work with.
It's excellent. In the interest of time, I think let's take the last question from you. It's a mic there.
Thank you. Hi, Rubaiyat from Endless Foundation. So when we think about like access and equity, we can't forget the fact that we have an absolute shortage of resources out there, right? Like governments are not allocating enough of their budget to healthcare. like the global north is not contributing enough to the global south, and so on. And the kinds of screenings that Ed, you were kind of talking about and you're already doing, we probably have the money to do like supply the basics, but then beyond that, you have the uterine prolapse, you have the child with cleft, you have the person who needs a bypass surgery. So all of these needs that can be screened but cannot be supplied. I actually lose a lot of sleep thinking about the coming wave of AI and people having consultations with AI and really knowing what they need but can't access it, right? So if you suddenly have like millions and millions of bypass surgeries that you can pinpoint, like that individual in remote Kisumu County in Kenya needs a bypass surgery now, how do you actually get that to them, right? And what's the solution to that problem?
Well, and one thing that we've done in Botswana is we now actually take surgeons out to these hospitals. They used to have to be sent to Gaborone, to Princess Marina Hospital. And we're not talking about operations that can be done. So we are taking actual surgeons out to the district hospitals where they have the facilities. They've had brilliant facilities, but they haven't had the specialists. So that's not a silver bullet, but that's one way that you stretch your scarce resources.
Louise?
Yeah, no, I think what you're describing is the perfect example of being over-focused on the technology and the product, and then we forget, all the messy stuff around it, like, there are no health workers, there's no resources, there's no capacity. So that's why you need a systems lens to it. You got to think more holistically around solving for public health and look at the people as whole persons with all kinds of issues, and how do we build stronger health systems that are focused on primary care.
You have a good point, Sam.
I'm just in agreement with what she just said. The health system needs to work, and the innovations that we are coming up with are just enablers to, leapfrog other ideas.
Ed?
Yeah, just in a way, for what it's worth, we constantly struggle with this. I mean, when we do a lot of community data collection up front. There's all the big vertical programs. We know where a lot of the funding goes. I'd say the number one issue that we see this year is mental health, especially adolescent mental health. And we're genuinely struggling with this because there's not enough psychologists. We know there's not. We don't want to start Medicaid. We don't want to start distributing psychiatric medicine just yet. That's complex stuff. Do we even start a program? We're happy to fund a program, but we don't know if we can break that referral to care. We haven't done it. And, the examples that I'm talking about a lot internally, it's like if I tell you your house is about to fall down and you're going to your house is going to collapse, but I've got no bricks and wood to fix it, or your car's about to break down and the wheels are about to fall off when you're driving, but I've got no more wheels, sorry. Would you prefer to know? Would you prefer to not? I mean, I would personally prefer to know. Personally, even if I know that nobody can help me, it's better to know. But it is like do you open a wound you can't heal conundrum? For us, we are only starting stuff that we know we can fix. That's our current position on it. But this is like something we talk about like every week. And yeah, I agree. The system has to be fit. A lot of what I'm saying about health tech nowadays is that it puts a fancy digital front door or digital veneer on a health system that can't help people. Yeah. So I don't know why, there's this like obsession with tech a lot of the time, including from Reach 52, because you're sort of putting this digital door onto incapacitated health system in many cases. So yeah, health system has to function.
Great. Those are fantastic points. Really insightful discussion here. We need to stop in the interest of time and move on to the next topic. Again, very great, discussion here. Really, I mean, there's so much to cover here, so much to do. But thank you all for your time and for your insights here. Let's give them a big hand before we let them go. Thank you. I think want to take 5 minutes break. Okay, let's get a quick. Okay, take a. Okay, good.
We're gonna start right back in about 5 minutes, and look forward to the second half of this conversation.
I think we can get it started now.
Yeah, it was like Fernando was my next, he's my neighbor. Then I jumped in. All right, good. Yeah, it's pretty much.
Dangerous.
How human beings, we are very yeah. Your surroundings and yeah.
All right. I think most people are in, so let's get started. This is the part 2 of our discussion here on end-to-end access. The conversation is going to move more upstream now. So we are going to talk about product development and market shaping. We did talk about demand a little bit, but in light of the earlier discussion, I think it will be good to have a conversation on overall product development and market shaping. To do that, to have this conversation with us, we have our distinguished panelists. Let me introduce them one by one. Right next to me is Yaneth, Giha, Executive Director of FIFARMA, which is the Latin American Federation of the Pharmaceutical Industry. Next to Yaneth is Michelle McCreary-Heath, Founder and CEO of Biotechity Clinical. That's no, it's hopefully I didn't do. It's a biotech plus equity. Okay. And then the last one here, but not the least, is Dave Ripin, Executive Vice President of Access Programs and Chief Scientific Officer, Clinton Health Access Initiatives, CHAI. So as I said, we are going to talk about product development and market shaping. And we will have some questions, just like the previous panel. We will have some questions directed to each one of you, and then we will have some more general questions where anybody can and all of you can talk about. Maybe I will just start with you, Michelle. You have tremendous experience across bench research, industry, and government focused on biomedical innovation and related policies. So you have experience from private sector, public sector, on the research side, as well as on the policy side. As you consider the last mile challenges that our prior speakers highlighted, how might we best link R&D and product introduction efforts to enable improved access? So that's, I think it's a big question, but you can handle it.
Thank you, Shyam, and thank you for having me. I think it's been a fascinating set of conversations. I'm going to focus on 2 elements. First of all, in reaction to the last panel, I think we have to have a conversation about what we're preparing the world for. Are we preparing the world for established therapies that have been around a long time with the ongoing model that they will constantly be 10 or 20 years behind higher income countries? Or are we preparing them for the next coming wave of biomedical innovation? And I think we have to really step back and say what is more equitable. Because while, of course, you need working healthcare systems, of course, you need more personnel and more manpower to be able to deliver all these new drugs, new or old, we have to be thinking about what's going to have the biggest health impact in the long run. I think the example of insulin earlier on the last panel was a very curious and interesting one, because screening is wonderful for diabetes and it's important, but delivering insulin, you have to almost have a continuous glucose monitor. I mean, sticks are really difficult to manage if you're really diabetic. So maybe we can look even further upstream and say, okay, how are we going to deliver the GLP-1s to countries where we see growing rates of diabetes, so we don't even have to be worrying about this in 10 years. Now, that may seem on the face of it as the most expensive and extreme solution, but actually from a long-term public health impact point of view and what we're seeing on its impacts on cardiovascular disease and other chronic diseases, it may be the most equitable health solution down the line. And so as we think about cutting edge technologies, we shouldn't be preparing the world for outdated modalities. We need to be preparing the world for what's coming down the pike. And while that may seem like an oncology drug today, being prepared to be able to deliver gene therapies may be the solution for sickle cell tomorrow. And 75% of sickle cell is in sub-Saharan Africa. So I know it takes a mind shift, and a lot of our global health community grew up in the public health world. My mother's a public health nurse who used to go door to door, so I understand. And the thought of that whole training mindset is, let's get boots on the ground and deliver primary care. But that's not the direction medicine is heading. So we need to kind of balance that really heartfelt and coming from a good place motivation with the science. And so I think that's really important. Now, we talked a little bit about affordability on the last panel as well. And that's what we're focusing on Biotequity Clinical. We're looking at reducing the overall cost of developing these new therapies. And 70% of drug development costs are the clinical trials. So if we don't find a cheaper, faster way to get the data we need to have confidence in our new therapies, then we will never be able to solve either our domestic health problems or our global health problems. So thinking about things kind of a little bit more upstream, I think will help us.
It's a really great point. Just a follow-up question to that, Michelle. How do you bring this into your product development early on when you are planning the R&D, from obviously clinical development is a big part of it, but right from the discovery side?
It's so important, and it's getting around more of the boardroom tables, I think, of our large pharmaceutical and our biotech companies now, because I think the rare disease halo period is waning, and people are realizing that the real impact is going to come from addressing large, common, chronic, non-communicable diseases. And so we're starting to have more of those conversations around the table, and that's really important. And because of that, people are starting to say, okay, how are we going to make sure our clinical trials involve sites in lots of different types of countries? How are we going to be able to deliver at launch some of these new cutting edge projects? I know that has been incredibly important in the sickle cell front, for example, not always successfully, but at least it's now becoming part of the conversation. So it has to start at conception. It has to be part of your clinical trial strategy, because even in the US, we see centers that are involved in clinical trials always get first access to new medications and new therapies. And so you have to be thinking about an equitable way and a fair way to involve a range of communities in clinical trials so that they can also get early access to the solutions.
Yeah, couldn't agree more. Let's get to Dave now from CHAI, Clinton Health Access Initiative. So Dave, you and your colleagues have pioneered approaches to market shaping. And I know that I used to work with you guys when I was at Gates Foundation. So we worked together on some of these things. And this great work coming out of CHAI on that, on the market shaping side. You looked at how to address market failures in creative ways. A couple of things to point out. You have led efforts to ensure equitable access in areas such as treatment for HIV, for Hep C. And some of that was again together with Gates Foundation. So quite familiar with that. Where do you see the best opportunities to expand and improve approaches to market shaping? And how could we develop better evidence along the way, and recognizing the point that Katharine made about lack of evidence in this field? So would love to hear your perspective on that.
Yeah, a lot there. And I mean, I just first want to say, I think this day has gone in the right order. We've talked about need, funding, demand, and now we're talking about products to solve the problem and how to get them out. Not, I have a nifty hammer and now I want to go out and find things to smash with it. Ultimately, market shaping is de-risking the investment that needs to be made to develop and get a product to a place, and the customers need an ability to pay for that product. And it all flows from demand. And by demand here, I'm talking about demand that's going to be bought. It's the intersection of need, available funding, ability of the health system to deliver. That's your demand. So everything has to flow backward from that. I want to make a brief comment to the upstream, and then I'll come back to market shaping. I think ultimately groundbreaking technologies, we need to follow the science and go for what works best for patients. But then as a product developer, you have to know your customer. You have to know what the program who needs your product is capable and designed to deliver. And you have to make product design decisions that suit the customer. An example I'll give is I have a new biomarker that helps me distinguish, let's say, a fever that's either viral or bacterial. If two companies develop it, one puts it on an ultra expensive, state-of-the-art, high throughput piece of equipment, sits in a central lab, and another develops a really cheap, fast to use rapid test. Only one of those products is going to succeed in the market, because you have to know where the patients need results and where the system is meeting patients. So I think there is give and take between innovating and developing products for the systems that exist. And I think we have to find the intersection so that we're developing best technologies in the best format. Coming back to market shaping, and starting with demand, we have chicken and egg challenges all down the line. Ultimately, that demand that we're going to use in market shaping, one of the biggest unknowns is the funding that's going to drive that demand. Sometimes we have to build a new health system. I would argue we have pretty darn good health systems in a lot of LMICs. It's a matter of just like breaking out of our silos and using health systems for what they are. Ultimately, funding follows a lot of things, including advocacy and activism. And I just wanted to touch on the very last question from the last session about what do you do about diagnosing people when you don't know how they're going to access treatment? And I would use actually a market shaping example where countries led the way, hepatitis C, where Egypt and Rwanda were at the forefront of shaping the market. And in both cases, it was taking the risk to find people in need of treatment. And you're not just diagnosing patients, you're diagnosing partners, you're diagnosing communities, and you're diagnosing activists. So I just want to re-emphasize, you've got to lean into the demand, or else none of the market shaping work follows. Okay, so we saw the presentation. We've done lots of market shaping, made billions in investments in vaccines and drugs. But honestly, we've gone after the easy markets. We've gone after the markets where there's bilateral and multilateral funding. It's not private sector care. It's not generally fragmented care that's led by local insurance agencies or governments. It's consolidated demand. And there's a lot of reasons for that. It's not just the same drug, it's the same stocking unit, because everyone agrees on a common set of quality standards and all of these other things. So we're all negotiating for exactly the same thing collectively. When that happens, we do see countries leading the way. I gave the example of hepatitis. One of my favorite examples is access to viral load testing, which frankly paved the way for our ability to go after HPV and cervical cancer elimination. It paved the way for us to be able to respond very quickly in LMICs, faster than the US and Europe, by the way, on virologic testing because we had the platform set up. And the market shaping was led by South Africa and Kenya, two countries who represented a large percentage of the global demand for virologic testing at the time. So market shaping can be and needs to be more country involved and country driven. And it can be very fast. The volume guarantee for dolutegravir, the newest best-in-class HIV drug, managed to introduce that drug at a lower price to the previous regimen and transitioned 18 million patients over the course of only 3 years, one of which was during COVID. So we can act quickly if you design a product that matches the health system, that matches the needs, and matches the funding available. The challenge, though, is we've done the easy stuff, and now we're looking at areas which are not covered by multilaterals, where there's large segments of the population seeking care in the private sector. Different governments have different epidemiologies of disease and therefore different priorities. And we need to look at a new round of market shaping where we address the localization and regionalization of both health needs and production and supply. Maybe I'll park there. There's a lot more I have to say, but I'll wait for the right time.
Yeah, no, I think that's great, Dave. I mean, and you gave some really good examples here. I believe now Egypt is completely Hep C free. I think that's the
yeah,
news
and Rwanda is going to complete elimination this year.
So I think these are really great examples here in terms of the demand and market shaping. I think we can move on to the pharma industry. We have a really great representative here with Yaneth. You represent the pharma industry across Latin America. So you have good experience from the industry side, but you also have good experience from the government side, from the senior leadership, of the government, as well as some other sectors. So we'd really love to hear your perspective on how might industry best support global access to health products, including in low resource settings. I mean, we see some examples coming out all the time, but we'd love to hear from you.
So thank you, Shyam, and very, very happy to be here today. Just a few more words about FIFARMA. FIFARMA is the Latin American Federation of the Pharmaceutical Industry. So we bring together many of the companies that are, the big pharma companies, but we do it regionally, and that gives us like a different perspective that helps us connect with the global, organizations, but also go into the national entities and stakeholders and try to really work together with all the challenges and all the opportunities that would mean for an organization like ours. So basically, the first thing that I would have to say when we talk about how can we, the private sector, help is taking action. But to take action, we need to engage more and better. We need to have common understanding of the challenges. Sometimes we think something, but then you go to the country, to the government leaders, and they think and feel something different. So understanding, like, together, what are the challenges is a key aspect of the way in which we want to approach the situations and the challenges in the region, but also trying to create together the solutions. Again, sometimes, you have the temptation of going and saying, this is how it works, this is what we have to do. And because I come from the government side and I worked so many years in the government of Colombia, I know and understand that, this is something that we need to create together or co-create together, which is a word that many use, but in which I think there's a huge opportunity. How we've done it in FIFARMA so far, I'm going to tell you quite, initiatives, simple ones in which we've been approaching the governments and working with, having this regional umbrella, connecting with the global experiences, best practices, and trying to bring them to the region. So 2 things that we usually do. One, we develop studies with international organizations. So I'm going to mention 2 of them. And these studies, what they do is that help us engage better in the region and having more data and information and sit together with the stakeholders in the countries and create this initiative. So for example, the first one, a study that we developed this year with WE4 or Y4 Institute from Germany, a health economics institute. Krishna knows the study, and Ernesto also, in which we try to analyze the socioeconomic burden of 7 diseases in 8 countries in LATAM, trying to show really the relationship and the impact of these diseases in productivity and the development of the countries. So we have figures there. This study is available in a webpage. And the incredible thing about this study, more about the figures, it says that we have lost between 2018 and 2022, something like almost $900 billion in productivity. This is like the main, but the thing is going into the countries with this data and trying to find ways together to overcome this type of situations that we're finding. So that is one. And the second, which is more famous in LATAM now, it's our FIFARMA weight indicator. It's a report that we've done for 2 years now. We're going to launch the 3rd version next week. We do it with IQVIA Institute. And there we see how much does it take for innovative medicines to come to countries in the region. So after it's approved by FDA or approved by EMA, how long does it take and how many of them are in the region? So only to give you data from the last version, because the new one, I'm not allowed to talk about that. It's going to be next week, and you're all invited to the webinar of launching. But the study is also will be available. Of the 228 medicines that we had for oncology and rare diseases, only 130 are in LATAM. The ones that were launched 5 years ago, only 130 are in LATAM, and of them we only have 86 with regional availability in one country of LATAM. Brazil or Argentina. So we go there and we start. And a lot of those are only, available in the private sector. So, it talks about the challenges that we have in the region. So these are studies, and we go, for example, with the weight indicator, we have sat down with stakeholders in the countries in the region and say, okay, how can we close the timelines? How can we bring innovation? Because innovation coming in sooner is innovation going into the health of the patients better and sooner. So it talks about the patients in the region. And I'm going to finish with the second part of my question, my answer that has to do with capacity building. So again, one thing is engaging and trying to use data and information to engage better, but the other is bringing knowledge, bringing best practices, or connecting. So, and in that, I want to talk especially about regulatory agencies. We have very different levels of development and maturity of the regulatory agencies in the region. And that also is a key aspect of access and a key aspect of all the health sector. So we've done a series of, we've developed tools to provide capacity building, or something that we did last week, which is interesting, is Anvisa is the most developed regulatory agency in the region. So last week we organized with DIA, we organized in Brasilia a whole day meeting with all the regulators in LATAM to come to Brasilia and visit Anvisa, so Anvisa could tell them how all the development have been. Because if we put them to talk with Swiss Medical or to organizations in Europe, they would say, "Oh, those are too far away. Those are we don't compare with them." But if we put Anvisa to tell them and to teach them in a way, and to talk about their progress, it makes all the difference. So that's another thing that we do, and another way in which private sector definitely can help in the region to try to overcome obstacles and challenges that we have.
Oh, that's great. Is there talk in terms of Yaneth looking at regional regulatory harmonization?
Exactly. That is, and that last week's meetings, in which, you see Anvisa right now is sticking very much to all these best practices in the world, reliance, basically harmonizing their processes with other agencies in the world. And Anvisa is right now a member of basically, all the important, instances regarding regulatory issues in the world. So that's something that we want to also promote in the region. Harmonization. In the region, there was at one moment they were trying to create an agency just like EMA. And I remember having a meeting and saying we should start first by harmonizing. Before we go and think about having a regional organization or one regulatory agency for the region, which is going to be very difficult. why don't we start by harmonizing? Why don't we start by reliance?
Yeah.
Why don't we start by, using what other regulatory agencies have already evaluated and approved abroad?
Yeah, that's a really good point. I mean, this is a big discussion in LATAM, especially under the Brazil G20 presidency. Health equity and access is big on the agenda. I think end of this month, we will all be in Rio for the health ministers meeting. And this is top of the agenda, which is, I'm really glad to see that. Let me ask some general questions here before I hand it over to the audience for questions from the room. Couple of questions here. So then, based on all of this discussion, what types of partnerships? So we are again talking about partnerships here. We talked about public-private partnership, multi-stakeholder coalitions. But in your mind, based on your experience, what type of partnership could accelerate access efforts and make them more sustainable around the globe? Are there particular examples of success or failures, for that matter, that you can share?
I mean, how can you say anything bad about partnerships? And I mean, it's such a broad area. I mean, I can think of several examples. We've had instances where donors who are very focused on supporting upstream investments like biotech investments in fundamental research. And we have found that when those are done in partnership with organizations that have a market presence in more than just upper income markets and are bringing a diversity of understanding of the markets to which the products being developed will ultimately be delivered, you end up with a better result. And, we can give, I can give an example even in the HIV space where the consequences of making a simple design decision in a clinical study, like, I'll test and see which patients have characteristic A, B, or C after I randomize them, has an impact on what ultimately the WHO and countries are willing to write in their treatment guidelines, right? So same drug, same technology, you design the study differently, and all of a sudden, everyone has to do resistance testing before they start the treatment, as opposed to knowing this treatment works in everyone, regardless of whether you're doing resistance testing. So that's one type of partnership, very upstream in helping develop products which are appropriately adapted to the problems being solved. I think, there's clearly also partnership opportunity in developing and commercializing products. Originators and biotechs tend to develop for upper income markets. And then once the approval is done, then they start thinking, what am I going to do about access? Maybe I'll give out licenses. Maybe I'll do this. Maybe I'll do that. I think there's a much better way where from the start, when you're making products to try out in your phase 1 and 2 clinical studies, why not partner with a company that's a large generic supplier who can give you a lower cost manufacturing base? By the way, increase your profit margin when you commercialize that product in the higher income markets. And you eliminate all of that period of time when you're doing licensing and tech transfer, and you reduce the gap between product launching in the first market and product launching in later markets. And there are various examples of companies licensing and partnering on access farther before approval and later after approval, and the results are pretty much exactly what you would expect.
Well, that's good, great examples here. I mean, you see some of this happening. Today only I saw that Gilead partnered with 6 generic companies on HIV PrEP, drug. So I think you want to see more and more of those, and probably early on rather than later on, as you said, in the life cycle. Your perspective, Michelle?
Well, I was just going to add that we have camps in the biomedical development pipeline. There's the regulatory camp and the insurer camp and the developer camp. And bringing all of those various viewpoints together earlier and at a global level, I think would be very, very useful, and I have never seen it done. And that would help us with some of the points you raised about regulatory harmonization. I remember when I led a regulatory group, it would take us 5 to 7 years to get to our 158 markets. And that was just the regulatory side of things. So that time and expense cost lives. And so this is for already approved therapies in one market, right? We're not talking about things that are experimental. So how can we start to shrink that? How can we come together? And your point about we've done the low-hanging fruit already, and now these are the sticky wickets. You know, where you have insurers involved, either private or public, when you have health systems that are maybe more established and involved in low and middle income countries. We need to bring those folks to the table to figure out maybe we need new coverage models. I know at the US state level, they're talking about for gene therapy, maybe money back guarantee coverage models. When you think about the ability to cure someone for life, it's maybe worth the upfront investment if you know you are going to yield the result. So we need to have some creative conversations now that we're on to those more difficult questions.
No, absolutely. I think value-based healthcare. I think that's something that we all have to pay attention to look at how can we start to, pay more attention to outcome-based models. But I think, let me hear your perspective rather than giving mine.
Yeah, I think that, maybe I'll give like a complementary perspective regarding the word, because I don't know if I'm going to talk of partnerships or of collaboration or, of anything in which we bring several organizations together. And I think I always tell my team a phrase that I learned from a colleague many years ago. I always say, we need more logos and less egos. And at the end, you and it's true. I mean, I remember listening to that quote and saying, I mean, he's so true. I mean, so, in so many moments in life, we just need to sit down, trust each other, and do things together. I mean, sometimes you're like trying not to tell the other what you're doing or don't collaborate because you don't trust the other. And sometimes, and in the health sector, I think in every country of the world, there's no agent that can do anything by itself. Never. So you need to sit down. So I don't know if it's a partnership, a collaboration, an alliance, whatever it is, we need to sit more and we need to work more together. I think COVID was the moment in which we realized that big problems need, collaborations, need all of us together, innovate in the ways and, really do things in other ways and speed up things up. I remember in our countries, in the region, things that were there for a long time, in the urgency of COVID, they started, running. So it's possible. Sometimes what we need is a sense of urgency and a need to collaborate and trust each other more. And, we've been trying to do a lot of, we see projects and partnerships in the region a lot, commercial ones, but also there are breast cancers alliances in the region that are really getting to incredible results. So we're seeing that collaborating is the way. So, what we need is more of that. It doesn't matter the word we use for that.
Yes. But you said the key word, which is trust.
Yes.
For any partnership to succeed, if your trust is not there, it's not gonna work. Last question. So you look at the pipeline now. You look at the pipeline of health products. What are you most excited about when you look at the pipeline in terms of potential health impact over the next decade? Let's say. What end-to-end issues do we need to address now to make sure we can accelerate access to those products that you are excited about? Maybe just we start from you, Dave, and we can go through that.
Sure. It's a huge question. I am intrigued and excited by the prospect of gene therapy for sickle cell disease, for HIV cure, ultimately for a number of things. I don't believe that the current form of gene therapy, where you literally have to kill somebody's bone marrow before you can treat them, is going to be the best way we can deliver that. I think we need to be investing as much in thinking about how we make those products cost effective and deliverable on a large scale as we are in developing the technologies themselves. But also say, we have a lot of stuff on the shelf that we're not using, and it's frustrating as all heck. We can treat sickle cell disease for, roughly $15 a year after a $2 screening test for infants. 90% of children die of sickle cell disease if undiagnosed before they're 5. And we're seeing very little in the way of investment in that space. Next year, hepatitis B and C will overtake tuberculosis as the largest infectious agent of death in the world. We have an ability to cure hepatitis C with greater than 95% efficiency. We have the tools today to eliminate hepatitis C. Instead, next year, it's going to be one of a combination of 2 hepatitises that are the largest killer in the world. So, I see a lot of exciting new technologies, and there's a lot we can do to make them accessible. But I also see a lot of phenomenal technologies which have been delivered to us, and we've got to figure out how to make the most of those too.
Okay, great. Thank you, Michelle.
I think I'm most excited by the mindset shift that I've seen recently. I mean, I think we've gone in the last 10 years from being satisfied with managing disease to thinking it's attainable to cure disease. And we don't know how to do it for the vast majority of illnesses yet, but that's now our ambition. And I think that is a very valuable and important ambition and something we should all be striving for. And COVID is an interesting example of lots of things, but one thing it's an example of is no matter how good you get at prevention, no matter how good you get at vaccinating and intercepting disease occurrence, you still need therapies. You still, no matter how much you fix the social determinants of health, people are going to get heart disease, diabetes, stroke. And we need to make sure we have great therapies and interventions for those people who eventually fall through the cracks of aging, because it's going to happen. And that ability to look at those really, really difficult cases and say we might have the technology to cure them is, I think, really exciting.
Thank you. I see the time warning here on the screen, so we might have to speed up a little bit. Yaneth?
I'll do it very quickly. I read recently a book called Extra Life. I don't know if anybody here has read it, Stephen Johnson, and one of the phrases, I'm gonna say 2 phrases of that book because I wrote them down. The first one is innovation is about the things that no longer happen. So, and he talks about, for example, the fridge and the innovation that, and the impact that something like the fridge brought to our lives. And we no longer talk about that. Or the seatbelt. We no longer talk about antibiotics, or we do talk about, but not to recognize basically where we are. Or I always think about anesthesia. I don't know what the world will be without the anesthesia. So, what would, in 20 years, we would be talking about or not talking about many things because of innovation. So, I like the way he puts it. And I think there are 2 things that are changing, or trends: precision medicine and artificial intelligence. I mean, those 2 things are definitely changing innovation and the way things are getting to us, and the treatment, but the diagnosis. So many things are changing. And basically the challenge, I think, and that was part of your question, is how can we, and I think about my countries in Latin America, are we really understanding what is coming and the trends? Are we really, adapting our regulations to receive them in a good way? Are we really understanding the challenges of capacity creation that we need? So, there are things there that we talk about in our countries, because definitely we need to be prepared to receive these new innovations. And let me just finish with this phrase, because I don't know it, but I don't know it by memory, but I loved the phrase of the book. It says, if the first great revolution in human health was extending the overall average of human life, The second should be about closing the gaps. And I love it because it talks about equity, it talks about so many things in it that, you know, was part of this conversation today.
That's very good. Good way to close, Yaneth. But can you imagine the world without antibiotics?
No, we can't.
Cannot. I mean,
No, we can't.
You look at AMR, what's happening now and what's projected by WHO 10 years from now, just a simple thing like AMR can, wipe us out. Not to scare people here, but that is certainly a scary scenario. Yes. But we have a couple of minutes here. Let me open it up for questions from audience here. No, I think there's one question in the back. You can give the mic.
In Mexico, Pfizer in Mexico, I get to know Direct Relief, Janet. I don't know if you...
It's an NGO.
Oh, yes, of course. And since that, they gave me always medicine. They send me like a list of all the medicines that are near to how do you say, to caducate or to caduce. They're ready to caduce, and I tell him, oh, I need this, and they send me, and they also send to the government. And that's nice. I think it's a good and comfortable way to distribute. And well, it's wonderful because for example, in closing the gap of hunger, we have worked a lot with the banks of food. Now in Mexico, there's a large network of that it comes from Egypt, the example, and it's working very, very well. And I tell them, oh, look, do the same with pharma, no, because it's very important that pharma that is treated the way it should be and distributed to the people that they really need it. No, so it's wonderful, the effort, and well, I think this initiative, I have to celebrate it. Thank you.
Thank you. Any other comments, questions? There's one out here.
Hi, everybody. Jen Bay from the American College of Cardiology. My question is for Michelle because you blew my cognitive doors off when you said GLP-1s and not insulin, and I've been thinking about it ever since. My organization focuses a lot about guidelines and thinking about evidentiary standards for care. And that change, that transition is relatively recent, right? So how would we think about that? Because clearly you've thought more about this than I have, in terms of if the science has moved to a different protocol that could, that is very expensive, but we'll put that to the side, but that could help more people have access to care by virtue of how it is provided, right? Much less frequency and much less sort of continued maintenance. How should we be thinking as the global community about pivoting to that updated science and implementing it? Because if you think about what it takes to stand up programs in countries, there's also a lot of lag time there. And so I'm really wrestling with that.
Well, I think COVID was an interesting example around this front, right? Because it really took coming together and saying, okay, how are we going to get a good sense of the global market scale? And once we did that, you could back up and talk about financing, maybe not 100% successfully, but you could talk about financing and you could talk about distribution. So I think having a sense of the global need, what would it even look like to shift to that as the expectation? And then if so, how do we then make the justification for bringing down the price? How do we make the justification for the refrigeration that would be needed? Any of those things. I think you have to make those economic arguments and trade-offs and calculate that balance sheet before you make that move. And guidelines are always some of our slowest, our lagging indicators, right? So I love that you're grappling with it, but I do think we have to be forward-leaning with these guidelines. We get so preoccupied with the rearview mirror that we lose sight of where we're even driving. And so that I think is important.
Yeah, I mean, maybe I can jump in on that as well and tie it back to the last session. In the HIV space, we've gone through a progression of better and better treatments. And when we've engaged with governments to say, you know, here's this next best treatment, generally the first question is, well, what's coming next? I'm going to plan for that. And if it's convenient for me to take this thing I have now and it gets me on a path to getting there, fine, I'll do it. But a lot of LMIC programs are essentially an opportunity to leapfrog to best solution, as opposed to cycling through all of the old bad solutions very quickly. And, you know, I think those programs have a great willingness to do that. They all want to know, you know, what's the next great thing? I want to design to that. I don't want to design to the last old thing that's just finally now available to me.
I had a med school professor who his adage was never be the first to prescribe a drug and never be the last. Which is, it's very interesting, right? Because his whole point was the first is going to change. You're going to learn more things about it, right? But the last, you're not actually doing your Hippocratic duty if you're prescribing the least of what is available. So finding that balance is tricky.
Okay, thank you. I think we have ran out of time here. We are already 5 minutes delayed. I don't want to come between you and your drinks. So I think we need to get there fast. But really, I mean, fantastic discussion, you know, I mean, great insights from all of you here. So thank you for being here, and thank you for your comments and your insights.